Good afternoon, everyone. Let me present you my progress in my topic, advances in endoscopic ultrasound-guided biliary drainage. My name is Panagiotis Paraskevopoulos. I come from Greece. And yesterday, someone made me realize that I've been living on and off in Budapest for basically 1/3 of my life, which is 9 years now. And so I'm like half Hungarian, but a bit happier, I think. And I have two topics. One is about hepaticogastrostomy versus hepaticogastrostomy with antegrade stenting for malignant biliary obstruction. And the second one deals with the devices and outcomes for the hepaticogastrostomy procedure itself. So for my first topic, let's talk first about the numbers. These are Hungarian data. In the national average CRCP procedures per year in Hungary, it's approximately 106 per 100,000 people. So if we extrapolate from the total population, that is approximately 1,060 ERCP procedures per year. And if we assume a 5% failure rate, this is approximately 53 failed ERCPs per year. So for that reason, there are approximately 4 people per month that would need alternative interventions. And I'm mentioning that because my supervisor likes to say that this is a niche topic, and although I agree, neural nets and virtual reality and all that used to be a niche topic also. But eventually, when the technology matures and people can benefit from it, people can use it. So, in the last decade, the endoscopic ultrasound-guided biliary drainage has emerged as an alternative option, and compared to the percutaneous biliary drainage, is associated with significantly better clinical success, lower rates of post-procedural adverse events, and fewer interventions. But there are many different procedures, and data has not been used extensively. We only have basically data for hepaticogastrostomy and choledochudodenostomy. So my topic is basically about the addition of the antegrade stent in the procedure. But let me explain you what these procedures are basically. So in percutaneous biliary drainage, you go through the skin into the intrahepatic bile duct, and then you place the stent. For the endoscopic biliary drainage, you would go from the stomach, you would pierce the stomach, and then you would go to the intrahepatic bile duct, the B2 or the B3 segment, and then you would place a stent between the stomach and the intrahepatic bile duct. This is one. For the antegrade stenting, basically what happens is that you go through the same route, so from the stomach, you go into the intrahepatic bile duct, but in the end, you're just going to place normally the stent as you would in a percutaneous biliary drainage. The difference, of course, is that in this case, you do it not from the skin, but from the organs. And this has two main advantages. One of them is that the C fibers in our internal organs are like diffuse pain, so you don't feel that much the pain. And secondly is the infections, because from the skin you can get infections much easier. So these two procedures can have the same indications, mainly surgically altered anatomy. So we can combine them and get the best from both worlds. We systematically searched. We reached 25 articles. 4 of them are direct comparisons, and the rest are indirect comparisons. So let's start with the direct comparisons. For the technical success, which is at the top left, this is, of course, something that was expected. Adding 2 stents is harder than adding 1 stent. And for the clinical success and the adverse events, there was basically no difference. I would also like to draw your attention to the reintervention rate, because it has reached or close to its statistical significance. And we can see that with the addition of the antegrade stent, basically 1/3 or half of the patients don't need reintervention. Now for the indirect comparisons, we reached statistical significance in all of them. And of course, again, we can see that technical success is much lower compared to not adding the second stent. For the clinical success, we can see that there is a slight advantage in adding the second stent. The reason for that is the two drainage routes. Because if you have two drainage routes, the bile can just flow easier naturally. And for the overall adverse events, they were pretty much similar, although the thing is that these are the overall adverse events. The good thing is by adding the antegrade stenting, the prevalence of bile leakage, which is one of the most significant disadvantages, it can basically cause sepsis and peritonitis, was very, very much reduced. We had one event in 200 people compared to 28 in 470. So that is very positive. So we submitted the manuscript 3 times. Now in the 4th one, we got a major revision, and I'm planning to resubmit it next week. So for my second project, you can imagine that with the advent of new procedures, we can also have new devices that we can use for these new procedures. So there is suddenly a market created. In the case of the stomach, because it's a movable organ, you can imagine that the stent will move and it can just migrate, which is basically one of the biggest drawbacks of the hepaticogastrostomy procedure. And this can, of course, lead to bile leakage. So for this reason, there have been novel devices such as stents with anchoring hooks. So you anchor the stent to the stomach, and in this way, it's just going to stick there and not leave. And we can use them to minimize the risk associated with the procedure. For my PECO, I'm just focusing mainly on the plastic and metallic stents because these are the ones that we have direct comparisons. So for the plastic and metallic stents, we can expect that, of course, for the metallic stents, the patency is going to be much higher, as is the case also for the ERCP procedures in general. But there comes side effects because cholangitis can be like a problem. But still, for the indirect comparisons, we have gathered and we are going to compare the different stents, like, as I mentioned, the anchoring hooks or the other ones, laser cut, braided, and other types of stents. And with the second projects, I'm in the data extraction phase now. I'm planning to finish it soon. And this has been the summary of my 2 projects. And for the additional activities, I have attended the Semmelweis Symposium. And the one activity, if I should say, that gave me the most pleasure over the last 2 years, for sure, by far, was teaching at this basic medical course by the University of Debrecen. It is licensed in Budapest, and like seeing, younger people from different countries, from Asia, from Africa, from Middle East, it has been like a really, really enjoyable thing to work with them. So that is all. Thank you very much for your attention.
Thank you very much for your nice presentation, and congratulations for the demonstrated results. Any question from the audience? Please ask questions. Yep. Use the mic, please.
Congratulations. Regarding the first project, I was just wondering that have I seen it correctly that the inclusion criteria were patients with distal biliary obstruction for hepaticogastrostomy?
Yes, that's absolutely correct. The reason for that is because all of the articles actually had only distal biliary obstruction as the cause. So this is why. But it could also be like cholangiocarcinoma, but it's not that oftenly encountered. So most of the patients had distal malignant biliary obstruction.
Mm-hmm. And how did you address this in your article? Because the current recommendations only recommend hepaticogastrostomy in the case of proximal biliary obstruction. So how did you address this in the article?
Actually, this is something that I'm also trying to understand, because from the anatomy, what I can guess is that you can very well have a distal obstruction and have hepaticogastrostomy, because if it's at the level of the common bile duct, then you wouldn't have any problem for the drainage. On the other hand, I could guess that for choledoduodenostomy, that would be a problem, Because if it's at the level of, like, if you have a Klatskin's tumor or a cholangiocarcinoma, which is at the level of the common bile duct, then if you place a stent between the common bile duct and the duodenum, it would not drain. So I have also encountered this, and I don't understand exactly the reason that this is written in the literature. But I have not also performed the procedures, obviously.
Its complication rates, it's a bit higher than the choledochoduodenostomies.
Yes, hepaticogastrostomy, I would not actually recommend it. It's a much harder procedure, for sure. I think all the duodenostomies are much easier, have more patient benefits.
Say it again.
Choledochoduodenostomy.
Say it again, please.
Choledochoduodenostomy.
Is easier.
Yes, from the common bile duct to the duodenum.
EUS guided choledochoduodestomy.
Do you agree?
Yeah.
EUS guided.
EUS
it is
guided,
easier if you have a dilated common bile duct, which is very close to the duodenal bulb. So you can make you can use a lumen opposing stent to put there, and it has much less complication rate and really easier to perform than connect the left lobe of the liver to the stomach, which moves a lot and.
I like more the because the duodenum is a tough organ. If you have a complication with the duodenum, you have a real problem. If you have just if you have the stent between the stomach and the left liver lobe, it's okay. So, but for me as a surgeon, a complication in a duodeno-choledochos stent can cause more problems than is a gastro. Gastro.
No, I agree, but I think the main problem is the stent migration with hepaticogastrostomy, because it can migrate much, much easier. So I think you would more frequently encounter a migrated hepaticogastrostomy stent than a choledochoduodenostomy.
How's the incidence?
I do not know, but looking at the plots of the time to stent dysfunction between the two procedures, it is much, much more frequent. So like 200 days and you're done, the stent. But if you add the antegrade stenting, the time just reaches 700 days. So it really, really helps. I have these plots, but I didn't present them. So adding the stent actually increases the time to stent dysfunction significantly.
So, let me go back again to Balin's question. What was the percentage of patients with distal biliary duct obstruction and more proximal in your articles?
I think there was none with proximal. I think there were
none with proximal, all with distal.
I think so, yeah.
Can you go back to the forest plot charts for this, the results of this? Yeah. Direct, indirect comparison. You mean that the article contained only one way of doing this procedure, technical success, clinical success.
So, like, you could even see in the reintervention that it significantly decreases. The reason for that is if you don't have a stent dysfunction, you would not need to reintervate. So this is why the reintervention rate is so much lower compared to without the addition of the antegrade stent.
What do you mean with antegrade?
So you know, like ERCP is endoscopic retrograde. The reason for that is because we go opposite to the bile flow. So we go from the duodenum to the common bile duct. Antegrade means that we go with the bile flow. We go from the common bile duct to the Vater's papilla. So it's just like a nomenclature about like the flow.
Sorry.
If you go from the stomach into the left liver lobe, it's also retrograde.
No, because then you will go to the common bile duct and then you will go to the Vater's papilla. Like here.
But you enter the system retrogradally.
The what? Excuse me?
You enter the bile duct system retrogradally.
I think
They are doing these procedures if you cannot enter in the usual retrograde way.
Yes.
So that's why you need US guidance to puncture either the dilated common bile duct or the dilated intrahepatic duct. So you are going antegrade, and it's either you are just doing the stent between the left lobe and the stomach, or you put an additional stent over the
again from the stomach.
stenosed part and going into the duodenum, right?
Yes.
So one stent or two stents. That is the.
And I would also like to mention, which I think is great, that my supervisor actually performed one of these procedures. So I think that was fantastic because it's really, really hard. But he actually performed it.
Any other?
Thank you, Pana, for your progress. Could you please define, or what's the difference between technical success and functional success?
In the articles, some articles had it written as technical and some others are functional. They're basically the same thing, but the different articles defined it differently. So how they defined it is by the bilirubin concentration. Some articles defined it as a decrease of 50% in 2 weeks, other ones 60 in like 1 month, so something like this. What we did so that we could pull them all together and we could not have like this heterogeneity is we said that it's like at least 40% within a month. So this is how we did it so we can pull them all together. And this is how we defined clinical success.
Right, thank you. And my other question is, what kind of adverse event you pulled together? What was the most common based on this data?
The most common adverse event? I don't know, not know. But I can definitely say that bleeding was one of them and stent migration was the other. But the most common, I don't know.
Thank you.
Thank you.
I have a very general question. So, and of course, thank you for the presentation. It was really nice. So why do we need random effect meta-analysis? Why don't we just, I don't know, average or calculate the mean of the proportion of the studies? So why does one need this sophisticated statistical tool?
So instead of a fixed, we usually choose random because we assume there is like an inherent difference between the different studies. So I think that's the reason. We assume a standard error and that they are not similar.
Tell us more about your future projects. Panos, what is your, and it's an,
I wish I had.
yeah, what is, I mean, it's, Panos, so you have the indication for a gastro, how say it?
Hepaticogastrostomy, yeah.
So yeah, I think we have two patient population, two. One is the patient we need for just for preparation for surgery, for distal biliary tract obstruction, or for proximal, for the perihilar carcinoma. And you also have a bunch of patients with end-stage disease for palliative treatment. So do you see any difference? Is there a difference a patient who needs maybe 4 or 8 weeks drainage ready for surgery, and the patient who has to in a palliative treatment? Do you think this has an impact on the stenting? Which kind of stent you use?
That's a great question, thank you. I definitely think that for the patients that are assumed to have better outcomes, the addition of the antegrade stenting should be chosen, for sure, because it leads to higher stent patency. So, of course, like pancreatic cancer and perihilar cancers, all of these have a very low survival chance. So in the case of using the antegrade stenting for the patients that you think are going to live longer, it's going to benefit them surely. And I don't think...
Panos, what do you think? You have an obstruction, let's say you have a peripheral obstruction.
Mm-hmm.
The liver, both liver lobes are has a cholestasis, and you put a stent in the left lobe.
Mm-hmm.
What is about the right lobe? You think you also treat with the left lobe stenting the right lobe? The question is more from anatomy.
Yeah.
My name is not Alan Alpa, but
I think that if there is a way that you could actually like make a connection, a fistula between the lobes, and then repurpose it to another location. Like
we're dealing with a distal tumor, a pancreas head tumor, for instance.
Yeah, but for a pancreas...
Terrible question.
No, it's great, yeah.
Just think about the anatomy. It's...
Yeah. I don't know what to say, but I will consider it.
It depends on the level of the stricture, whether the left and right lobe are separated from each other or not. If you have a distal bile duct obstruction, those are not separated.
They are not separated.
If you are doing just one puncture, that drainage all of the liver. Yeah. If you are otherwise, you have to try.
Okay, now I understand.
Okay.
Mm-hmm.
Okay. Any more questions? Oh, thank you then. Thank you very much.
Thank you.
Congratulations.